Hey, DPC docs, listen up because the big, beautiful bill just passed, and we know you've got questions. What does this mean for HSAs? How does it impact your patients or the future of DPC? My DPC Story is teaming up with the DPC Coalition to bring you answers. Head to mydpcstory.com/contact and leave us a voicemail with your questions, and we'll be covering them in upcoming episodes. Again, that link is mydpcstory.com/contact to leave us a voicemail. Elation Health wants to support all those looking to start their own DPC practice. For that, they created a checklist for how to launch your own practice. Learn everything you need to know about planning to open a new DPC practice, from Medicare opt-out requirements to legal advice, financial support to marketing know-how, and the technology resources available to DPC physicians. With Elation's EHR, ensure your patients receive high-quality, proactive care through an intuitive clinical workflow while reducing manual work and charting time. Elation Health's EHR supports you throughout all stages of your DPC journey. Visit elationhealth.com/mydpcstory to download today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
DPC means, to me, freedom, autonomy, and having the best care for my patient.
Direct primary care has the potential to change medical care in the United States like no other institution or facility can. Primary care physicians have the unique ability to break away, to start their own practice, to reject the notion that big hospital systems are necessary, big insurance companies are necessary, and maybe even that they're hurtful, that we can reestablish the relationship with the patient on an individual basis. And we, as a group of primary care physicians in the direct primary care model, can guide the country to the healthcare that we think is best. We know best. We see people every day.
I'm Dr. Samia Suleman.
This is Dr. Karl Hanson of Infinity Health Direct Primary Care, and this is our DPC story.
Welcome to my DPC story this week, guys. I'm so excited because I am doing this interview in person with Dr. Karl Hanson and Dr. Samia Suleman, who are at Infinity Health DPC here in Kenner, Louisiana. I have not been to Louisiana before this trip, and it is so exciting that we get to chat right after the energy of the DPC Summit. So thank you both so much for joining us today.
Thank you for having us.
We're so happy to be here.
Dr. Hanson, I'd love to start with your story of the day that you opened DPC in Louisiana. What was the environment like? Because there's a lot more DPCs now than there were when you opened.
It was an adventure. It was not a common thing in Louisiana. There may have been just one other DPC practice that was open a few months before I opened Infinity Health.
Wow.
So there was some discussion about it, but quite honestly, at the time I opened my practice, literally the previous year, I knew nothing about direct primary care.
And what year did you open?
2016 is when I converted from my insurance-based practice to direct primary care.
And your insurance-based practice, was that a private practice? Were you part of a group?
It was private practice. I was in solo insurance-based practice.
Yep. And what was your scope of practice, and how many years were you in that private practice before transitioning?
I've been in solo practice since 1990.
Mm-hmm.
Spent a couple of years out of residency working for a multi-specialty clinic, and then got irritated at that and went solo. And I've been in the insurance-based practice ever since as a solo practitioner.
Because of that history, especially with you going from a multi-specialty group to solo, what did you see in terms of how insurance was changing over time at your practice and for your patients before you went to DPC?
Well, there's a big story to that is I'm actually one of the founding physicians of a Medicare Advantage plan in the state of Louisiana. And that started in the late 90s as we built that plan. In the process of being part of that plan, I was witnessing more how the sausage was made, about the different regulatory burdens that gets placed upon us, and how it kind of became a behemoth. And then that just amplified some of the game. I never got involved in the RVU game because I was never employed, but I did get to see more and more that the whole CPT challenging game was just not something I wanted to continue to do.
Absolutely. And how did you see it affecting accessibility for your patients once Medicare Advantage went live and once insurance did what it did over the last couple of decades?
Well, accessibility, even in the insurance days, I had a relatively small practice. So I was able to see people whenever I wanted to. Remember, I was my own boss. So I could do that whenever I pleased. So accessibility was not a big concern of mine. The major concern was that I really wanted to do primarily patient care and not even be concerned about the administrative game that we've all acquiesced to.
Absolutely. So now I'll turn the mic over to Dr. Suleman because I'd love to hear your foundational story when it comes to what was life before life at Infinity for you.
Well, so I had the good fortune of meeting Dr. Karl relatively early in my career. After residency, I spent a year, my husband and I, in Ireland, spent 2 years practicing medicine out there. So that was quite the change, and it was a great learning experience for the both of us. Returning here, I, again, had the good fortune of meeting Dr. Karl, and I was doing insurance-based practice as well as dabbling in a little bit of DPC, having a hybrid practice a little bit.
Wow.
So we shared an office. And I got to learn a lot more about DPC, how it works. And I could see firsthand all the troubles of the insurance-based practice, the hassles, the chasing after, trying to get paid, things like that. So it was a great learning experience. We joined forces about 1.5 years ago. That was a great turning point for me. I enjoy what I do so much now.
I would love to hear what you saw and if anything that you saw overseas in a different healthcare system also impacted the way that you looked for how you would continue to practice when you went back stateside?
Well, there was a lot of autonomy, so I thought that was great. There's a lot of room for learning. Where I was working, I was at the University Hospital Limerick, and it was an acute medical unit. It was a mixture. You would have some people that had insurance and then some people that were funded by the state. You really didn't turn people away, which was great. That included seeing patients for DBTs, working up MIs. It was a hospital-based practice.
And when you talk about that you knew Dr. Karl early on, I would love to hear what you saw from your eyes and your perspective, because I think that this is a time where medical students and residents are really seeing what we're doing because there's so many more of us. It's easier to find resources compared to when you opened, Dr. Hanson. So I would love to hear what it was that was impactful for you to see, especially for those listeners who are new to this movement, whether they're talking to their friends or seeing their attendings do DPC. What did you see that helped inspire you to eventually be a DPC doctor full-time?
During residency, you had the option of rotating with Dr. Hanson. I graduated 2014. It was a new concept. It was enticing. It was, can this really happen? So it was a lot of different emotions.
Dr. Hanson, I want to turn the mic over to you now because this is fascinating to hear. And you went to LSU for residency yourself, correct?
I did. I went to LSU Medical School and then LSU Family Medicine residency. Yeah.
And so I'm wondering, similarly, how I asked about the insurance over time, engaging with residents over time, what have you heard from them in terms of what am I going to do after residency? What is out there? Am I able to be, a full scope doctor if I wish to? What are some of the things that you've heard from residents? Because Dr. Suleman was one of your residents before.
Well, when I talk to residents, and I'll go to residency programs and give a talk, and I don't talk about thrombocytopenia or anti-gaps. I talk to them specifically about how to start a practice.
Yeah.
I talk about the joys of private practice and owning your own business. So that's actually been my focus with interacting with residents. What I tried to transmit to them is, again, a lot of times as we're getting close towards the end, they talk about finding a job.
Yeah.
And I just reiterate, you do not need to find a job because you make your own job. That we have to quit looking at ourselves coming from a sense of barrenness or helplessness, et cetera, that we need to assert ourselves because we are the main cog in taking care of patients. So that has always been my focus. The biggest obstacle is that, of course, these guys and gals have probably never run a small business.
Sure.
They're petrified. They have debt overhanging. There's nobody else that surrounds them, meaning in academia or their hospital rounds, who is giving them information on how to start a private practice.
Yeah.
And the fact that not only is it possible, but it's ideal.
And when people are mentioning these fears about finances, about I don't have an MBA, how do you start breaking down that mindset of I'm just a physician, I'm not a business owner?
Right. Yeah. The main thing I say, to run a small business, you don't have to have an MBA. You just have to be able to pay attention to detail. And the fact that you've made it through pre-med, med school, and our residency, probably one of the things in your talent stack is to be able to pay attention to detail. And know also that probably some of the people that you went to high school with didn't go to college and right now are running their own small business.
Totally.
So don't diminish yourself, don't demean yourself. And then just giving them the realization that to become a physician, you sort of have blinders on. You're not paying attention to some of these business things out there. Doesn't mean, though, that you can't pick it up in short order. The first bit of advice I give to them, when you're thinking about doing a small business, don't think about the small business and that fine detail.
Yeah.
Do baby steps, start a process. First, think about what do you want to call your practice and your logo.
Sure.
And that's all.
Yeah.
And don't think of, and once that seed sort of gets planted, then you're going to start inching up and learning bit by bit what goes on. And then also, I have an open invitation. If any of them want to start a small business, small practice, I'll personally help them with no consult fee or anything, just to walk through everything.
Yeah.
So,
That's incredible. So Dr. Suleman, after coming back from Ireland, what made you go the route of leaning more and more into DPC versus opening your own DPC versus just going fee for service, urgent care? There's so many pathways that we can take as physicians. And I also intentionally say that because if you are worried about DPC financially, definitely having a side gig is one of the ways to help finance a DPC. But for you, what was your journey in how you made the decision to become a doctor at infinity?
So I also come from a family of physicians. My father's a surgeon. My mother's a pediatrician. My sister's an OBGYN. They all were very much in support of me being in an independent practice.
Sure.
My father's always been in private practice throughout and has kind of been the held out, not being bought out by the hospital.
Yeah.
I do wound care as well. So I have a side gig with nursing homes and doing some wound care there. But the way I chose doing DPC is I had started with having some insurance-based patients and things like that. It was just the ease and the attraction of not having to worry about paperwork, not having to worry about all this overhead, getting all these prior auths, having all this trouble with being regulated so much. And I would see the way Dr. Karl would work and his patients, everyone's happy at the end of the day. And I would still have paperwork and stuff going on. And I was just starting.
Yeah.
So it was kind of seeing so much ease.
And I'm wondering if you could both talk to any concerns, fears, or challenges that you had after deciding to start DPC, because Dr. Hanson, you at the time, like you mentioned, DPC was not as much of a thing as it is now. And Dr. Suleman, you're seeing a better way to do things, but especially for somebody who's graduating residency, when most people go to employed medicine in a corporate situation, I would wonder if each of you could share any challenges or fears you had before you started your DPC journeys.
The challenges and fears I had, the apprehensions, let's say, were that you were taking a steady book of business because you have to run a small business, means you have to pay bills and et cetera. And I was going to just throw all those 1099s away from the buckas and just trust and hope that a sizable fraction of my patients would sign up with me. So some of it is a personal reflection is that what if nobody signs up? That's not just a monetary insult, of course, but that could be sort of a personal gut punch that nobody wants to stay with you. So when I made the decision, which was a relatively rapid decision after going to the 2015 DPC summit, after 2 months, I was all in. Primarily, most of the anxiety, I think, was my wife was not quite comfortable, and we were both nervous, maybe not nail biting, but there was that apprehension about taking an established business and leaving and changing the model.
Yeah.
I think that was a major apprehension. Otherwise, the positive aspects of it was what maintained the drive to continue and actually pull the trigger on it.
That's awesome. And I will ask here, what ended up happening once you transitioned to DPC? How many of your patients said, great, what you just tell me, where I need to sign, what I need to pay, and how many of those people were asking about, like, what are you doing? And how many of those people were saying, nope, no insurance, not going?
Well, the first several months leading up to the actual when I put out the announcement, I would casually talk to my patients, hypothetically, if somebody was, et cetera. So I was getting a vibe or a feel for it before I really came on the final decision. So it's hard to give a percentage because you don't know if you see a person once a year, once every 3 years, are they your patient? But I know it was revenue neutral for sure. In other words, the income I lost from 1099s not coming in from Medicare and et cetera, compared to the enrollment that I have, it was a little north of actually revenue neutral. So I don't know. I never actually went back and calculated. I'd probably say maybe I had a 35% conversion rate, maybe 30%.
Fantastic.
But I never really drilled down on it because it didn't matter, just moving forward.
Absolutely. And how many patients did you start with on day one, or did you onboard them slowly so you didn't have all of your patients just transitioning over? Because some people out there are concerned about that in terms of transferring their private practice to DPC, like Dr. Michael Chun has shared on the podcast before. But what was it like for you? Because you owned your business, you owned those records, and then you just were doing a different business model.
Stay with us. We'll be right back.
Thinking about hiring a virtual assistant but not sure where to start? Cool Blue VA does more than place VAs. They partner with your practice. From a full practice audit to help you uncover what tasks to offload to 80 hours of free trial support, they help you figure out what to delegate and when to hire. We dive into all of this in our latest episode, so don't miss it. If you're at the DPC Summit this week, visit Justin at the Cool Blue VA booth in New Orleans. And if you can't make it, be sure to catch the episode and learn how to get 80 hours free of VA support for your DPC practice. Find the episode in your podcast feed or check out the link in the show notes. Are you a DPC provider tired of EHRs that feel like they were built for someone else's practice? Serbo was specifically designed for practices like yours, cash-based, membership-driven, and focused on building relationships, not red tape. With Serbo, everything lives on a single screen. Charting, lab orders, prescriptions, and billing. No more tab overload or wasted clicks. Need to prescribe supplements, manage IV protocols, or send a refill straight from the chart? Serbo has got you covered. Want patients to schedule online, sign forms, or message you securely? Serbo's custom-branded patient portal makes it easy. Thousands of functional and DPC clinics trust Serbo to run their practice without the admin chaos. So if your current EHR is holding you back, it's time to level up. Visit cer.bo to schedule a demo and see what Serbo can do for your clinic. Healthcare communication today is overwhelming, with practices managing multiple disconnected channels, making coordination difficult for providers and care delivery frustrating for patients. Spruce Health solves this by unifying HIPAA-grade phone, texting, faxing, and telemedicine into one secure, easy-to-use platform. With Spruce, you can organize all communications in a centralized inbox, automate workflows, and collaborate seamlessly. No app required for patients. Missed calls are transcribed, messages can be scheduled, and urgent issues are routed instantly to the right care teams. Spruce is purpose-built for healthcare, securing patient data with encryption and robust privacy controls while offering flexibility through shared inboxes and tracking tools that support accountability and oversight. From solo practices to large teams, Spruce streamlines communication, improves efficiency, and enhances the patient experience. Start a free trial today and discover why thousands of practices trust Spruce for healthcare communication. Spruce, where healthcare communication counts.
the bulk of my patients at the first month or first instant of direct primary care practice were patients that I already had charts on, who already had a relationship that were just moving over from my prior sole proprietorship to Infinity Health. So these were people that didn't have to be all of a sudden taken in on the first month. So the people that signed up, I may have actually just seen them literally a month before in the insurance-based model. I didn't face that challenge of a large volume of people coming in that were new to me. Right?
That's really helpful because as we go forward, there will be people who are wearing very similar shoes as you were when you transitioned into DPC. So Dr. Suleman, you're graduating and you're looking at your co-residents, you're looking at the classes before you, you're probably hearing a lot of physician recruiters, because I sure did. What was going on in your mind when it comes to challenges or fears or apprehensions about the world ahead of you when it came to DPC?
I had done my year in Ireland, 2 years in Ireland, and so I had come back. Once I had came back, and so my apprehensions before transitioning to DPC were, is anyone going to join? Is anyone going to continue? Took a lot of deep breaths. I remember walking outside and, can I do it? Can I pull the trigger? It was, and I'm still working on this, and it's not selling yourself short. And a wise person tells me that. And that echoes with me all the time. And it's remembering not to sell yourself short. It's completely a journey. And I think you get the reaffirmation once you see your patients and once you get the affirmation from them that they are so happy, they are so thankful, they are so grateful, and it pushes you forward. And it says, I am doing a great service. They are happy, and it just keeps you going.
Amazing. And Dr. Hanson, I'll ask the same question of you. When did the discussions with your wife change in terms of, we got this?
Well, the DPC seminar I'm referring to was in the summer of 2015. And we mentioned before that when I was there, I was telling myself, I'm not doing this. This is not for me. And within 30 days, 60 days, that turned 180 degrees. And of course, we talked a lot. My wife and I talked a lot about it. And fortunately, she's an excellent listener and an excellent advice giver, and good advice, not just any advice. So we came to our conclusion pretty rapidly, within the first few months after the summit. Then there was a bit of the angst about the bells and whistles and the particulars of setting it up and how to write the letter and when to, that kind of minutia, if you will. But the major psychological transition took place within a few months after the summit.
And I'm wondering here if you guys can talk to us about Louisiana, because Louisiana is different from Ohio, is different from California when it comes to what the healthcare access is like, what the quality of care is like, who provides the healthcare. So talk to us about Louisiana as a state in terms of what is the medical care like around here, and especially around Kenner and New Orleans area.
Medical care in Louisiana primarily rural. Of course, you can say that about a lot of states. There's a fairly significant Medicaid population, and in the suburban area of New Orleans, which is where we are, there's been an adequate selection of primary care physicians. I think that's been okay. I think the change has been more recently where hospital systems have gobbled up practices and have also changed their model to a nurse practitioner based type of primary care, where it's difficult for patients to actually interact with their MD or DO without some layer of insulation. And then, of course, urgent cares pop up, which is a poor model because you're enticing people to get lesser care. Medicaid individuals, I would say, and I would preface it, Medicaid individuals are some of the most fun folks to take care of, because a lot of people who have Medicaid, they may not be able to get an appointment with their physician for a month or 3 weeks at the soonest. And so we all know in the medical world what that can lead to. So it's nice to be able to really help somebody that on the day of their illness, not 3 weeks after their illness.
Absolutely. And
how about you, Dr. Suleman, when it comes to who you saw in residency? Because as Dr. Hanson's talking about more recently, nurse practitioner, non-physician provider models, that is absolutely a thing we're seeing in most states. And when it comes to Medi-Cal and California, Medicaid around the country, how was it for you in residency?
It was a mixed population that we saw in residency, but a majority were Medicaid. And just to talk about how that translates to DPC practices, we have a mixture of patients. So we have patients with Medicaid, Medicare, no insurance at all. So what I love about DPC is you can see a wide range. It's not just that we're seeing like a concierge model that we're only seeing super wealthy patients or anything like that at all. We're seeing a wide range of patients who are interested in great care.
And yes, I love that because it really highlights how insurance is not healthcare.
Right.
And that is something that we are educating people about every single day. So I would love if you guys could talk about new patient coming to the practice, has maybe-ish heard about direct primary care, but is very much still like, I believe insurance is healthcare. How do you guys talk to them? A lot of people were practicing their elevator pitches at the DPC Summit. So I love how you guys talk to new patients about this practice versus the fee-for-service world.
So talking to new patients, people that have joined us, somehow or another, they've already had the discussion or talked to not necessarily us, but a friend or family member who's engaged with us. So somehow or another out there, the friend or family member has already done the elevator speech for us. So at that point, now when they come in for their initial visit, sometimes it's meet and greet, but usually they'll just join. They know, and now we're just sort of embellishing and enhancing what the specific details are about this, because maybe they have some misconception or something like that. But a lot of the ones that get referred by others, the others have done a fairly good job, word of mouth, of bringing them up to speed. And that's really great. Now, the sale, if you will, to individuals who have no contact. We all know that game because it's sort of like 3 levels of elevator speech. So the one between floors 1 to 10, 10 to 20, 20 to 30. So there is a bit of a challenge in that. We still have people that when you briefly mention it to, they'll say, oh yeah, I have a friend with that. You're MDVIP. And so we all have to face that battle of doing that part. But the patients that come in, they've been a little education already from their friends or family member.
And on that point, the MDVIP, I've definitely heard that a lot more while in Louisiana compared to in California. And I'm wondering, how do you guys differentiate? Because usually we hear, oh, it's concierge. But how do you guys specifically talk to the differences between MDVIP and direct primary care through independent physicians?
Yes, the thing is, it said, oh yes, I hear, Dr. Hanson, that I see you're in concierge. So I have to say, well, maybe the umbrella term concierge, but probably you're referring to a model that's a national company called MDVIP. And then they'll acknowledge that. And I'll just tell them, we don't double dip. We only get the monthly fee from the patient as per contract, and that includes all services. We do not do any extra billing or collecting for visits. And specifically in Louisiana by law, we do not bill any third party. We do not bill insurances. So it doesn't matter to us what your insurance is. I'm not sure that promotes direct primary care so much. So it's kind of more of a technical definition. But yeah, we do have to address that when we get lumped into every other form of concierge.
And I think it's important, especially now with the passing of the Primary Care Enhancement Act as part of the, quote, big, beautiful bill. This is where Jake Keese of the DPC Coalition has said, and I agree, this is where the work starts. Because now that we're even more visible than before, now that HSAs can be used without question for DPC member agreements, this is where I believe we have to keep fighting for, this is what we actually do. We are not the same as fee-for-service. We are not the same as concierge medicine. And this is for everyday Americans to access the same level of care without having a 7-figure salary or without having to go through your employer. So, Dr. Suleman, how about you? Because as Dr. Hanson's speaking, and you did have, you mentioned the concern about like, will patients join? how has your elevator pitch, so to speak, changed over time? Because I'm assuming you have to have some patients who knew Dr. Hanson's model who said, "Oh my goodness, like there's a new doctor. He might be on a waiting list. Like I have a chance, and I'm sure as heck going to take it."
Yeah. So my elevator pitch is ever evolving. Essentially, it goes with, we provide the services that you need. I'll start off with the issue. Are you having trouble getting in with your physician? Are you having trouble? Do you find that it's hard to get an appointment when you need an appointment? And we present the problem to them, and they'll say, yes, actually, my mom, I can't get her in. And by the time it's time for her to get in, she has to be admitted. So I start with that, and then I work around, well, with DPC, what we can do is you have access to your physician 7 days a week. You have a personal physician. It's bringing back the doctor-patient relationship, essentially.
Yeah.
And they're very attracted to that. And most of my patients love the fact that they can message me, "Hey, Dr. Suleman, I'm having sinusitis.
Sure.
I feel like I'm having an ear infection," and I will respond to them right away. You can come in. We have same day, next day visits. We have a very affordable membership fee. And along with that, we include our labs, and we also dispense. So there's so many perks, and they love that.
Yeah. And when you talk about membership fee, how did you, Dr. Hanson, create the membership fee? And has it changed over time? Because nowadays people say like, oh, the 3 clinics around me, they charge this much, so that's about what I'm going to do. But how did it work for you?
At the time that I was doing the transition into direct primary care, I recall seeing some published data what the average fee was throughout the country.
Mm-hmm.
And as I recall, it was $77, something to that effect. And then I factored in, okay, well, that also includes places in the Northeast and the coast and stuff like that where just things are more expensive. I chose less than that. Mine was $65 a month.
Mm-hmm.
I maintained that for a long time. About 2 years ago, I increased it to $75 a month. And I don't want to go more than that, because part of this, I do know that we could be charging more. I do know that. But part of the concept is that you want to keep this at the level that is attractive to people, that separates us from the typical concierge model, and that the average person would find it clearly affordable. And anyway, that's how it started. It was probably because I looked at what the average was in 2015.
Sure.
Whoever published that, I don't recall who that was.
Yeah. And in terms of the concern about affording direct primary care, we've had Dr. Stephanie Phillips on the podcast. She's in the poorest region of all of Georgia, and her patients are paying on average $75 per month to make sure they have access, as Dr. Suleman talked about, to their doctor who they know, versus one trip to the ER is more than 12 months at $75. So can you guys talk to us about the money conversation when it comes to the patient who says, that's too much, I can't afford that?
Definitely talk about how your Netflix bill, your electricity, just things that you do, or going out to dinner, or things add up and you don't even realize it. But also there are payment plans. There are things we can do to prioritize, and we try to make sure that we emphasize that your health is a priority for patients. And once they realize what the benefits outweigh saving a little bit more so that I can spend on my health, it makes a big difference, and it goes a long way for them.
Mm-hmm. And have you guys heard that, well, healthcare is too expensive because I usually have to pay $200 for a thyroid lab? Like, I can't add another membership fee on top of that. What do you say to those people? Because they aren't necessarily aware that you can purchase lab and imaging at prices that are wholesale like you could at the grocery store.
Right. So we do have contracts with the labs, and we do let our patients know that. And a lot of times our patients, that is a big draw for them. But there are people who do have an issue with the monetary aspect. And for them, it might not be a good fit at this time, but they always have you in the back of their mind. And that's the other thing, is that it's not for everybody. Not saying that, I mean, will make concessions for people, and like, again, like payment plans, things like that are always options. But if someone truly has a problem and can't, it's nothing that we had to force on them.
Yeah. And I think this is really powerful because we own our own businesses. We're able to not have to wait for 16 committees to tell us it's okay or for some code to change, to have a covered service. It's when I remember when I was in fee for service, I would just call a family because their family member was just diagnosed with cancer and they're the care provider and they're losing their minds as well as the patient. It's like, I have no idea what code that is. And now I'm grateful that I don't have to care. I just do things and you just get to be a doctor. So I'm wondering here in terms of you guys partnering together. I love this because we need more DPC doctors out there. There's not enough. And it is not that we are creating the shortage. The shortage is being created of physicians being out there because of the system. 100%. If you do not agree with that, please leave me a voicemail. But when it comes to you guys partnering together, this is absolutely a thing. You do not have to open up your own DPC. It is not shameful to just partner on with somebody. There's people doing just locums coverage. Dr. Brewer-Eberly had somebody come on at Fisher Health Clinic and cover as a locums while he was waiting to graduate residency. And so I'd love if you guys could talk to us about how you guys made this partnership at Infinity work and decide to do it.
Stay with us. We'll be right back.
What if your EMR actually worked the way you do? Introducing Hint Clinical, the electronic medical record intentionally designed for direct care clinicians. Purpose-built for new and growing direct primary care practices, Hint Clinical includes the functionality of a modern EMR, practice management, patient communications, and membership management all in one technology. Imagine quick, customizable templates that adapt to your workflow, secure patient messaging that builds stronger patient relationships, and simplified appointment scheduling with features like self-schedule and an integrated Google Calendar. Ready to explore the all-in-one EMR for direct care? Visit hint.com/clinical to learn more and get your first month of Hint Clinical for free. Run your practice your way with Hint Clinical. Imagine this. Your patients leave your office with their diagnosis and their medication in hand. No pharmacy lines, no delays, no confusion. This episode of My DPC Story is brought to you by AS Medication Solutions, your trusted partner for medication management made simple. ASM empowers physicians to dispense medications directly to patients in a way that is simple, compliant, and cost-effective. That means better access, better adherence, and better outcomes, all from your practice. Need flexibility or provide virtual care to your patients? ASM has you covered with mail order options too, so your patients can get the care they need wherever they are. ASM doesn't just offer on-site medication dispensing. They offer a care-enhancing tool that improves adherence, communication, and trust. Visit a-smeds.com to learn how ASM can streamline your care and strengthen your patient relationships. That's ASM, medication management made simple. Starting or growing a DPC? Then this is for you. At Jumpstart DPC Solutions, we don't just do marketing. We walk with you through the messy, exciting, overwhelming parts of building a DPC. Need a brand that reflects who you really are? A website that actually converts? Someone to talk through pricing, panels, or patient growth? That's us. We're accessible like your practice. Text us, call us, email us. We check in regularly and act like a true partner, not just a vendor. We've helped over 50 DPC practices build from scratch or scale with purpose, and we know what works because we live in this space every day. Go to itsjumpstart.com to see the difference. Jumpstart DPC Solutions, because your story deserves more than a template.
Yeah, I'll take this. So I really believe in direct primary care and that it's a wonderful privilege to be able to take care of somebody.
Yeah.
And I did want to see direct primary care expand to have more offerings. And technically I wasn't what I would consider full, but I knew Dr. Samia from before and her work ethic and her just ethic in general. And even though she didn't have this large subset of patients to import to the practice, I said I wanted to get somebody that was conscientious and kind of understood what the problem was out there. So that was really the genesis of the partnership. You want to get somebody who's a partner that you can trust, who shares the same ethic. That's kind of more important as opposed to what residency they came from or this kind of thing. So that was the genesis of partners. So we could expand the offerings of at the time my company, Infinity Health, expanded to other people out there in the world. So that was really the genesis for me.
Yeah. And how about for you, Dr. Suleman? Because when a person is looking to join a DPC, I wonder what your thoughts were. This apprehension is less because he's already open. What were examples of things you were thinking about when you were looking to, and when you finally decided to partner on an Infinity?
So I brought over maybe 8 patients from when I transferred over, but having a great mentor like Dr. Karl, it was key, because I could see how he was working with his patients and how his patients are extremely loyal, and he has a great following. And for me, it's an inspiration to work with him and to share, to be partners and be in this partnership, with seeing the work ethic and seeing how I treat my patients. And it's taking longer than I had expected, but my panel is growing, and I'm happy to say that my patients are very satisfied, and they give their testimonials, and they're very pleased with the model. It's just a lot of more of awareness that we have to get out, that DPC does exist, and that there are different options other than the insurance-based model. Yeah. And I think that's something that we all need to work on.
Yeah, absolutely. And I would love, because you are partnering, I would love if you could talk to the audience about what things do you recommend people either think about when they're joining on or think about when they're hiring?
It's like EMR software. No matter how many times you look at the demo, you never really know until you're 3 months into it. And then you say, what just happened? And it's the same way with finding out who's a good partner. So again, my advantage is that I had known Dr. Samia for years, one way or the other before this. So you get a better sense. So I would say, in looking for a partner, is to look somebody who shares the work ethic and the ethic towards patient care. And I didn't give her a quiz. I didn't have her take the licensing exam again or anything like that. So you can't really go with that, because direct primary care is a mindset. It's an attitude. It's an acknowledgement of what's wrong with the system and who the players are who are degrading the system. That's a bit of a rebellious attitude. So you're looking more for personality characteristics, in my opinion.
And how about you, in terms of what questions would you recommend people asking if they're looking to partner on at an existing DPC?
Again, I would say there's questions to ask, but more, is it a good feel? Is it a good mix? Do you get along? Do you feel like there's a mutual respect? It's more of a feeling, I think, than any questions.
And I'm wondering if you guys can talk to us about the legal structure of the DPC partnership. Did you guys partner, or is one 1099?
The full partner.
Yeah.
When I invited her in, it was the full partnership. There were those, and I did research, employee 1099 type of relationship, but I felt that I just felt like it was better just to demonstrate that confidence and that trust by creating a full partnership. And I'm glad it's been that way. I mean, I don't, but that again, that's because I've had a chance to know her before. It wasn't an acute situation where I had to take time to assess somebody's character, if you will.
Absolutely. And Dr. Tom White, very similar situation, is he intentionally looked for partners and not employees, just because that's also what he believed in terms of somebody having a career that is literally just DPC, and they have the autonomy same as us who open our DPCs on our own. When it comes to benefits for yourselves, health plan benefits, retirement, how do you guys address that at Infinity?
Well, I am 66, so I'm a Medicare. Before that, I was on a health share. My wife and I used to be on one of the typical BUCA policies. And we jettisoned that a few years ago and joined one of the health shares. My wife is still on the health share, but I aged into Medicare. So, and I have not joined a Medicare Advantage plan. I'm just straight Medicare. So that's how I handle.
And what about savings for retirement?
I'm a DPC doctor. Why would I want to retire? The saving, well, I've long had, as a solo practitioner, a simple IRA, and that's what we have here.
Yeah.
So now we all are in the simple IRA.
Yeah, fantastic. And how about you, Dr. Suleman, for your healthcare? And also, did it provide you a sense of security knowing that there was this addressing of an IRA? Because some people are coming on and they're like, we don't offer 401k, we don't offer any retirement, we don't offer healthcare. How was it for you?
Yeah, for my family, we do have insurance. Currently, not very happy with it, but we're looking at health shares and things like that now. As far as, of course, there's security in having a retirement plan and things like that. So that's always an attraction also. It gives you a sense of security. It gives you a sense of, this is something that I'm working towards, and this is for my future and for my family's future.
Yeah, awesome. Now, this weekend, not only was it the DPC Summit, but also the Louisiana Family Academy of Family Practice Medicine's State Summit, which is, Dr. Hanson and I talked about this before, that this is probably unusual that they have a state and a national event at the same weekend. But you were going between the two. And I'm wondering if you can talk to us about what it's like on the LAFP, I almost said CAFP, the LAFP side of things, because I want to, envisioning, just asking you that, I'm like, there's Stranger Things and then there's the upside down. So I would love if you could tell us your experience.
Okay, so this would be the second podcast. The LAFP, so I've been a member of the Louisiana Academy of Family Physicians for 41 years, and I'm involved with them, not administratively, but I'm actually in charge of a program of developing a module, kind of a go-to module for people that physicians that want to start an independent practice.
Fantastic.
Whether that's coming out of residency or whether it's leaving the indentured employment. So I have a lot of involvement with the LAFP and lots of friends over there. And it's kind of my home organization, if you will. It was kind of fun going back and forth between that and the Direct Primary Care Conference because there's quite a contrast, Everything from the exhibitors to the atmosphere to the presentation. Now, granted, one's a national organization, one's a state organization. And the state group does a very good job at their assembling. But yeah, it's a different vibe. There's so many ways to describe it as a different vibe, but both are valuable. But the Direct Primary Care Summit just kind of has a way different energy.
Yeah.
But that's probably the best way I could describe it. I think that there was just a mistake with the AFP that they scheduled it the same day. It's never happened before. Sure. And it's not that way next year. They're separated next year.
Yep. And how about you, Dr. Suleman? Because clearly you were at the summit as well, but when it comes to talking to colleagues, it is a very different conversation. Sometimes it's really uncomfortable to have talks about DPC because some people I've heard, they literally will say, it's because of DPC that we don't have enough physicians. It's because of DPC. I'm like, say all the things, and we can prove as a movement that these things are not correct.
I actually have not run into that at this point yet. People are actually fascinated by our model and what we're doing. So I get a lot of positive feedback, and I get a lot of questions about how does it work and how does one transition and things like that. A lot of doctors are fed up with the system.
Absolutely. Yep. So Dr. Hanson, this is definitely a question for you because of your involvement, 41 years as an LAFP member. I definitely see now way more education on the California side of things of what DPC is, especially for the people who are very seasoned in fee-for-service. We only do fee-for-service. We could never do DPC. Kaiser will never shut down, the naysayers. When it comes to the challenge of getting DPC representation at the state level, when it comes to even inclusion in conferences, how do you bring the voice of representation of direct primary care physicians and what direct primary care physicians in existence means for this academy, and how do we help DPC doctors in addition to you creating education resources about the model at your state level.
Stay with us. We'll be right back.
You didn't choose direct primary care to fight with your EHR. You chose it to give patients your best, and Elation Health is here to help you do just that. Our best-in-class clinical first platform is purpose-built for primary care, giving you the freedom to practice medicine your way. From seamless membership management to integrated telehealth, Elation streamlines the tools you need, so you can focus on what matters most. With AI-powered Note Assist, documentation is handled in real time, saving you hours and reducing cognitive load. Just ask Dr. Kenneth Richter from Scotland Family Medicine. As a DPC provider, my visits become easier. I'm not labored by coding or box checking. Trusted by DPC pioneers across the country, Elation empowers clinicians to deliver high-value, relationship-driven care without the administrative drag. Elation Health, empowering DPC practices to thrive through clinical-first innovation. See how at elationhealth.com.
DPC plus SmartHeart equals better patient care. SmartHeart is the world's most advanced portable 12-lead EKG system. Lightweight, wireless, and FDA cleared, it's built for modern practices that want to deliver fast, accurate, and accessible cardiac care anytime, anywhere. So easy to use, it delivers a full hospital-grade EKG in just 30 seconds. No technicians or extra staff needed. SmartHeart changes the game. SmartHeart puts hospital-grade 12-lead EKG capability in your hands, wherever care happens. In under 30 seconds, you can record an EKG that automatically includes unlimited preliminary reviews from the SmartHeart telemedicine service and access on-demand full interpretations from a network of licensed, credentialed, board-certified cardiologists. Returned within 30 minutes, every EKG performed can be compared to past tracings on the same screen. DPC doctors love SmartHeart for enhancing care, saving time, and unlocking new value for their practice. Better care, more peace of mind, new revenue streams. That's the power of SmartHeart. Book a free demo at smartheartpro.com.
I think the major hurdle at the Louisiana Academy of Family Physicians is for them to weave DPC in as a forefront model.
Mm-hmm.
There are certain things that would be in conflict with, for example, the typical sponsors that are at, for example, of course, at the LAFP event, some of the exhibitors included insurance companies, employers, etc. Obviously, there was none of that at the Direct Primary Care Summit.
Yeah.
And I think sponsorship may play a role in that.
Sure.
I've tried to address that, and probably I should be a bit more aggressive in a polite way with the local academy about bringing up practice models more. However, like I said, the resolution that I presented to the academy 2 years ago to develop this independent practice model, it was well received.
Great.
And it was embraced, I would think, and we're working on it. It's not ready for prime time yet. And I wish I probably could have done it on my own in less than a year, but you have to go through the system. So I think it's getting there. Also recognize there's a lot of docs in employed practice that are in the Stockholm Syndrome. And part of the Stockholm Syndrome is that you almost deny the existence that there's something better to do.
Yeah.
And you certainly don't want to, at no time do I demean anybody who's in employed practice, because it's almost a compassionate empathy
Sure.
about what they're going through. So you don't want to be aggressive. You kind of want to just keep yourself out there, offer yourself as a resource. It's kind of like I'm here if you need me type of thing in private. And I had 2 employed physicians come talk to me at the LAFP in private about what is this and what can I do to get there. So that's kind of what the level is now, that we're there for you if you need us. I'm not going to berate you. We understand. We've been there. So that's kind of the level of position I take.
Yeah. And I love this because next I want to ask about the Louisiana Direct Primary Care Coalition, because I think that as we are resources out there, I think that there's such a swell in the desire to know about DPC from physicians, new, existing attendings who've been in practice for decades. And this is why, we created our California DPC Summit. Extremely important to know, how do you do DPC in your state? And so tell us about the Louisiana Direct Primary Care Coalition, and where do you see that going in the future?
When I started Infinity Health in 2016, the following year, I created a coalition. We only had probably half a dozen DPC doctors in the state at that time. And so I created the organization, but did nothing with it because I felt like we didn't have any critical mass. And I converted to a 501c3, but still nothing has taken place with it. Well, right now in the state, we have 20 physicians that provide direct primary care to their patients, probably 17 or 18 practices, but some of those practices have a couple or a few physicians. And then also with the fact that when the Big Beautiful Bill was debated, there was a discussion about Medicaid, and DPC. And then, of course, there was the whole HSA insertion into that law. And so this year I felt it was worthwhile that we had the critical mass to get that going. So the coalition, and we're forming our board as we speak, the coalition is there to promote direct primary care in Louisiana, to demonstrate to Louisiana Department of Health that we can provide excellent services to the Medicaid population and make their health better and save the state money. And also to promote the proliferation or adoption or education of direct primary care within our academic facilities. So it's not a coalition that's going to be setting rates or telling what DPC doctors do. That's not our vibe.
Yep.
We're all lions and cats, not sheep. So we don't want people telling us what to do.
Sure.
The coalition's certainly not going in that direction. But anyway, the major focus is to promote DPC in the state and to offer our services and demonstrate to the state. And finally, in Louisiana, we have the Department of Health is very friendly to that and very forward-looking. It was really great to talk to the Surgeon General and the Assistant Surgeon General. Amazing discussions. And we want to go ahead and promote that because we think we have a lot to offer.
Fantastic. And where do people go to learn more about specifically the Louisiana Direct Primary Care Coalition? And does it also accept medical students and residents?
Right now, we don't have membership. The website is ladpcc.com, but we don't even do dues or anything like that. So there's going to be more to come, if you will, once we have some sort of strategy meetings and figure out where we want to go. But the website is open. I mean, and there's a contact email address, et cetera. So, and people have contacted me through that to discuss direct primary care in general.
That's great. And I think it's so important, especially now, because that was lovely that two people talked with you in private at the LAFP summit, but it is so important to have resources out there. So many people find rotations, just networking through our calidpc.com site for our California Direct Primary Care Coalition. So I think it's so important that if you're listening and you are having these discussions anyways, it's really great to come together, because I think that even more so in the future, again, like I mentioned, the work really starts now. This is how we really come together as physicians, protecting the physician-patient relationship. So
I would love to graduate to where you all are, where you're having a California DPC summit. So I'll be reaching out to you all to figure out I don't need to reinvent the wheel, what tips and tricks that you may have.
Absolutely. So can you tell us, what do you see for the next year, 3 years, 5 years at Infinity Health DPC?
Once our panels get full or are starting to approach that, I would like for Infinity Health Direct Primary Care to be more involved with teaching residents, to create a center of excellence of some type here where residents can rotate with us in more depth and detail. Of course, a lot of that's controlled by the Graduate Medical Education Board, how much what residents have to do. And some of that's actually we're a little bit worse this past year. So we're going to have to fighting that battle. But it's the same thing about talking to other practicing physicians, talking to residents and just say, look, hey, you don't have to just start signing up with big boxes. There's a real option that you can go through. And there are a ton of people out here, including Infinity Health and myself and Dr. Samia, that we will help you every step of the way in developing your business and developing your practice.
Incredible. Dr. Suleman had to step out, but thank you so much on behalf of My DPC Story for both Dr. Hanson and Dr. Suleman. Thank you guys so much for sharing your story today.
Oh, thanks for having me. This was excellent.
Thank you for listening to another episode of My DPC Story. If you enjoyed it, please leave a 5-star review on your favorite podcast platform. It helps others find the show. Have a question about direct primary care? Leave me a voicemail. You might hear it answered in a future episode. Follow us on socials at the handle @MyDPCStory and join DPC Didactics, our monthly deep dive into your questions and challenges. Links are at mydpcstory.com. For exclusive content you won't hear anywhere else, join our Patreon. Find the link in the show notes or search for My DPC Story on patreon.com. For DPC News on the Daily, check out dpcnews.com. Until next week, this is Marielle Concepcion.